cancers, the way we treat them, some of the like reasons why, you know, why we use leucovorin and all the 5FU regimens, and a little bit about side effects and a few questions, but honestly, this should be pretty open-ended and interactive. I really don't want to be talking the whole time, so I'll try to pause a lot to answer questions. And I mean, I talk a lot to the fellows and other like trainees and individuals, and so what I just throw out there is like, there's no stupid questions. There's a lot of things that, like, if somebody's thinking it, somebody else is thinking it and just not willing to speak up to ask the question. And there's a lot of things that even 3 years into just focusing on GI cancers, I still have questions about, so please use this to ask me anything you guys want. So we'll talk a little bit about GI cancers, specifically focusing on colorectal and pancreatic, some resources, examples, and questions. So myself, Dr. Reilley, Dr. Kunk, we all focus on anything below that dotted blue line. So, and you can see this is clearly British because it's oesophagus. And that's where we start. We don't treat any head and neck cancers, but anything in the esophagus through the rest of the digestive system all the way down to the anus is our realm. We also treat neuroendocrine tumors, which arise out of enterochromatin cells in the gut, primarily. There are lung neuroendocrine tumors, and
your call cannot be
sorry. Okay, I'm giving up.
And those go to the lung folks. We treat gastrointestinal stromal tumors because the word gastrointestinal is in there. However, those are really sarcomas. And then cancers of unknown primary, which sounds like it should be extinct with like better ways of diagnosing people. There's still about 30,000 cases a year where we don't know where the cancer started. GI cancers are common, and so this shows new cases per year. You can see colorectal cancers are about number 3 in incidences, number 3 for each gender in incidence. They're number 4 overall behind prostate, breast, and lung cancers, and then pancreas is down there near the bottom in terms of incidence. In terms of deaths, they're one of the more deadly types of cancer. You can see that even though their incidence is relatively low, their mortality rate is pretty high. And unfortunately, this reflects the broader situation that we don't have a lot of great treatments for GI cancers, and unfortunately, there's a lot of them kind of late in the course. And so if you look at this breakdown from the data from the American Cancer Society, what you can see is that particularly as you're getting to the right, anything on sort of in each graph, there's 3 sections: localized, regional, and distant, which I think is a more helpful way to think about these cancers versus traditional staging. Most localized cancers can be cut out, and you can see for like esophageal and pancreatic cancer, very few cancers are definitively treatable, and a lot present when they've already metastasized to other places. And so this next one's a little depressing. This is 5-year survival by stage, and again, most colorectal cancers, especially if they're early, do pretty well. Everything else does pretty poorly, even in early stages, and I think that's the really disappointing reality at this moment. And so, why do you go into GI oncology? Because this is kind of depressing. There's a lot of reasons. I think one is that you see patients across the board. So young patients, older patients, men and women, people from all different kinds of background. To some extent, GI cancers do have a environmental exposure, but there's not the same sort of like predisposition where everyone who gets certain cancers has used chewing tobacco or things like that. So it's usually, I can tell a lot of people that's just kind of bad luck that they got these cancers. there's close multidisciplinary care, and actually Thursday mornings where I'm usually here Thursday mornings for the GI tumor board that happens, and work closely with really lots of different specialists and lots of different providers. And it's a relatively high intensity relationship because these patients get chemo fairly continuously and it's fairly frequent. So, and then the last piece is that really there's a need to develop better treatments, and I have a lot of hope and excitement, and as you guys have seen, a lot of patients on trials trying to do better for these patients. Okay. Before I launch in, any questions at this point? All right. So colorectal cancers represent a large and diverse group of cancers. What's really interesting and sort of new is that there's this understanding that left and right-sided colon tumors are phenotypically and genetically different from each other.
Do we know why yet?
So
that's fascinating.
A little bit, and I'm gonna actually, I'll show you an anatomy picture on the next slide. And the other important thing with this group of cancers is that despite with better screening seeing a decreased incidence, and unfortunately this point applies to a lot of people in this room, there's a disturbing rise in CRC in the US population under 50. So it's one of the few cancers that we're actually seeing an increase in incidence, particularly in rectal cancer. And so this is the large intestine. You can see that obviously the left side of this, well, not obviously, but the left side of the screen is the right side of the colon. The right side of the screen is the left side of the colon. It's like if you were looking at yourself in the mirror. But if you draw a line like this, it sort of looks obvious that, okay, you could divide the colon into a left and a right side. And embryologically, if you look at the way that the gut forms, essentially there's two different portions of the early embryo that twist to do the, I was gonna do a slide of that, and I was like, you know, I hate embryology because it's so complex. But basically, if you look at the vascular supply, you can see that there's sort of two different portions. One portion that feeds the left side of the colon, one that feeds the right side, and that sort of reflects the fact that embryologically they come from different areas. And so actually Graham Casey here does a lot of genomic work and population health work, and he's been working with C. Powell, and they've been taking biopsies. So when people get normal screening colonoscopies, they're doing biopsies of the colons of patients and growing out these their tumoroid models. And what they've done is they've characterized those, and so genetically and epigenetically, they're just totally different. So like they're totally different on the right versus the left, and it probably is related to the embryologic origin, which is still, I'm hand waving saying that, but it's clear that they're very different genetically, and then phenotypically, and I'll get into this in a little bit, they respond differently to therapy and they have different prognosis. And so if you look at my clinic notes, I try to be really good about specifying for colorectal cancer patients whether it's a right or a left colon patient, because I think it's important for people to know that. So flipping back to incidence, I highlight this because one of the cancer center priorities, and really national priorities, is to address colon cancer screening and in high-risk areas. And we are, you can kind of see in the right side of that red circle, there's a blue spot, and that's like Charlottesville. So like here in Charlottesville proper, we have a relatively low incidence of deaths per every 100,000 population, but immediately to the right, it's one of the hot spots in the nation in West Virginia and Western Virginia in terms of sort of unexpectedly high deaths per population due to colorectal cancer. So one of the major goals of the population health program in the Cancer Center is to try to find ways to help that patient population in Western Virginia and West Virginia, and we're sort of uniquely situated here to help those patients.
Does there seem to be a reason as to why? Have they figured out what those causes are?
It's not entirely clear, and so there's certainly associations with increased incidence of certain unhealthy behaviors like heavy drinking, smoking, probably obesity, but why it's so bad. And you know, it's funny, I'm sure you guys have like talked to patients who will say, I have, you know, 3 people in my town who in the past 2 months have been diagnosed with colorectal cancer, and we all like went to the same place. And so I'm sure that there's an element of environmental exposure that's truthfully there, and whether it's from like some of the coal mining, whether it's some of the other industries, I'm sure there's a component of that. But it's really hard and hard to know for sure, and I don't think we have a clear answer. And this just reflects the other point that, so if you look at the incidence and mortality in sort of across all age groups, you see that in the 65 plus, in the 50 to 64 years, it's gone down over the past several decades, whereas in the 20 to 49-year-old range, it hit sort of a low in the 90s, 2000s, and then it's crept up ever since. And nobody's really sure why that's the case. I will say, if you think about it, well, is it genetic versus environmental? It's unlikely that there's been some kind of genetic change in young people recently that's contributed to increased incidence. It's probably something environmental. And again, hand waving, theorizing, I can come up with a lot of different ideas. I think it's interesting to me that one of the things that seems to be recognized more and more is this sort of microplastics that's going on in terms of, you know, all the like really sort of cheap disposable water bottles and things like that, where they're finding it in the ocean and certainly finding it in a lot of people. I wouldn't be surprised if there's some relationship between that disturbing the gut microbiome and like younger people having sort of differences in their gut microbiome these days than they did 20, 30 years ago. That's contributing to that. But again, this is not fact. This is me theorizing, so don't go telling any patients that like, oh yeah, Matt was telling us that this is probably due to drinking out of plastic water bottles or anything like that. So, yeah.
So along that note, then I've seen along with some of my friends, you know, 20s, 30s, that there's an increase in like probiotic use and stuff like that. If patients ask us about that, what do you think about them doing that? Like because they have so many different types of advertisements now with the prebiotics and the probiotics and the micro and macro, like it's like all of it.
It's super fascinating, and there's no question that, in my mind at least, that the microbiome of the gut, particularly with GI cancers, has a huge effect on metabolomics. It probably has a huge effect on the immune regulation of at least local cancers, maybe even systemically. What I tell patients, because I actually have this conversation a bunch with patients myself, is I don't have any hard and fast evidence to say yes or no. And so I don't inherently think that it's a bad idea. And I think in some cases, especially after like a course of antibiotics, it may be a good idea. What I do warn people are that there's case reports that if you're immunocompromised, or if you've had a recent surgery and there's a breakdown of the normal sort of barrier for a bacteria to cross, that there's case reports of people who've taken probiotics and actually had it get into the systemic circulation and then cause infections. And so what I tell people is that if they're immunocompromised or if they've had recent surgery, to not do probiotics. I literally just had a conversation with somebody yesterday who was about 4 or 5 weeks after the surgery saying, it's probably fine to do like Activia, things that have maybe a little bit more, but I wouldn't do full dose oral probiotics. But I think it's a really good question, it's a really relevant question, and it's the kind of thing that should and probably is being studied. What's also amazing to me is we probably don't ask, and a lot of people are probably doing it, so there's probably situations where this stuff is happening, we just don't ask patients, and they're doing it. So I mean, at least when I see patients, I really try to make it an environment, because I'd rather have somebody tell me and not have a like paternalistic sort of, you shouldn't, that's terrible, why did you do that? I can't believe that, like, you know, you would do this and not consult me before you started this. I'd rather have somebody tell me and say, oh, maybe that's not a good idea, than have people feel bad about things and, and not tell me that they're doing it. So in terms of staging, actually, colorectal cancer staging is kind of easy. And I'll go through it just briefly to say that, so it's divided into basically if the tumor does not go through the muscular propria, which is sort of the muscular of the colon, it's stage 1. If it goes through that, even if it grows into adjacent organs, it's stage 2. Once you have positive lymph nodes, you're up to stage 3, and then when it's metastasized, it's stage 4. And so really, the difference between 2 and 3 is lymph node involvement, and the difference between 3 and 4 is distant organ involvement. And so treatment paradigm similarly breaks down to anything that's not metastatic should get surgically resected. Even in metastatic cases, sometimes we can cure colorectal cancer patients, so we tend to try to be aggressive to get everything out if we can. And similarly, for stage 3 and 4 disease, chemotherapy is always indicated, at least as a discussion. Sometimes in stage 2 it is, and then the big difference between colon cancers and rectal cancers are the colon floats, so it's hard to radiate it safely, whereas the rectum is fixed in place, and so it's easier to radiate. And I will say I've thrown in a bunch of these sort of diagrams from NCCN. They always are fairly busy diagrams, so I put them up mostly just for reference, but what you can see is that the recommendations for chemotherapy in stage 2 and 3 disease is always 5-FU plus oxaliplatin. There's no other approved chemo for stage 2-3 disease. So for any metastatic colorectal cancer, you can do a whole bunch of other things, but the only thing patients should get for stage 2-3 disease are 5-FU plus oxaliplatin. So either 5-FU or capecitabine. And that's basically the same. So for metastatic disease, there's tons of options and combinations. There's 5-FU, fulfoxirine, bevacizumab, inotuzumab, cetuximab, trastuzumab, immunotherapy. And you guys have probably seen these all at different times, at different combinations, and at different doses. And I mean, I think it's great because it's a lot of different choices. When I was learning this, it's horrible because it's horrible to know which ones you use when and how you decide and what you, and it's also a lot of different drugs with different side effects, and because we combine 3 and 4 drugs together, it's really hard to know when one drug is causing one of the side effects, and we all experience that. So just looking through some of the trial level data, here's a listing of the common side effects with FOLFOX. What you can see is that everybody gets side effects. So at the top, the all AEs, and AE stands for adverse event, and that's just the way that these are classified in clinical trials. All adverse events are graded on a 1 to 4 scale, whereas 1 and 2 are what I would consider mild to moderate and usually not requiring large interventions. Grades 3 or 4 are when it's a big enough deal that you have to either change therapy or do some kind of significant intervention. And grade 4s are usually the severe infusion reactions, things that kind of require an immediate pause and assessment and interventions. And so everybody had side effects, and actually almost or more than 3 out of 4 patients had one of the more serious side effects. Usually the more serious side effects were related to either cytopenias or something that happened after the fact. And the most common was neutropenia, diarrhea was fairly common, everything else was less common. And so kind of my take-home message from FOLFOX is everybody gets side effects, but it tends to be a little different for everyone. And the things that I watch out for really closely are the neuropathy, because particularly in the adjuvant setting, when you're curatively treating people, it's a huge deal if people get permanent neuropathy. And there's a huge difference between 3 months and 6 months. And so I almost put all that data in here, but just to summarize it, at ASCO in 2017, they presented some of the results of the IDEA collaboration, and the IDEA collaboration was 6 trials in 6 separate countries that looked at doing 3 versus 6 months of chemotherapy in stage 3 colon cancer. And what they found is that if you get 6 months of oxaliplatin, there's actually, it's like a 12% plus incidence of permanent grade 2 or 3 neuropathy. And grade 2 or 3 neuropathy means that like you are permanently unable to like type or do things normally that you would have done before. And by dropping that to 3 months, you drop that incidence to like 1 to 2%. And so it's a conversation I have with patients, but basically if you have lower risk stage 3 disease, it's pretty safe to drop down to 3 months of therapy. And there's some evidence, and again, this is a little mixed, but looking at the Scottish population, which was the Scots trial, but it was one of the sort of subarms of the IDEA collaboration. They give a lot of capecitabine oxaliplatin, and what they found is that actually in the 3-month setting, it seems like the patients who get 3 months of capox did significantly better than patients who got 3 months of FOLFOX. And so I sometimes will have this discussion with the colorectal surgeons, because they'll be like, why are you guys giving so much capox? Because it's frustrating when the patients have like troubles with the capox, because the oxaliplatin dose is higher and capecitabine can be expensive when it's out of pocket. But part of the reason we do that, especially for a lower risk stage 3 disease, is the outcomes look like they're a little bit better. And so I have that conversation with patients, and it's not definitive. So I never tell anybody that like you are inherently getting inferior treatment by doing FOLFOX. It's just there's some suggestion they may be better with capox. And so this is just looking at the side effects of FOLFIRI and anti-EGFR. And so some of the big differences with FOLFIRI are that you get really hair loss, and I don't know, is that listed here, alopecia? But I mean, I tell people they get hair loss, or at least there's a reasonable chance they're going to lose hair. A little bit more in the way of, I tend to see platelet effects with irinotecan, and certainly diarrhea, and you guys are used to all the abdominal like muscle cramping. One of the things I didn't put in here, but it hasn't been reported on a lot of trials, and I've had discussions with a lot of you about this, is that post-trials, irinotecan seems to have this association with dysarthria, which is like the loss of ability to speak transiently while you're getting the infusion, which is kind of horribly scary when you're seeing somebody who can't talk anymore. And it's transient and it resolves, but it seems to be related to the fact that irinotecan, particularly the parent molecule irinotecan, before it breaks down into its active form, SN38, it seems to affect the same receptors that atropine works on, and so that's part of the reason why you get the abdominal, the muscular cramping, and it can affect the same nerves that allow you to speak. And so I had one patient who has had particularly severe reactions, and giving atropine at like 15 to 30 minute intervals has worked really well. And in fact, with him, we tried a bunch of different things. First, we tried spacing out the infusion time to see if a slower infusion would work better. And it did cause a later onset of it, but it didn't stop it. It just happened later. And the problem with expanding out the infusion time is you can't give like 8 doses of atropine because that's too much. So we ended up condensing the time back down and giving a total of giving it over 90 minutes, but giving atropine like every 30 minutes for that period of time. And it's actually worked much better for him, and he hasn't had issues. So anyhow, that's the kind of fun stuff to like, you know, if you guys, I appreciate how willing you are to like experiment with stuff like that to try to get a good answer.
So I mean, we were in a patient's room one time, and the patient was having some speech issues, and we couldn't tell whether or not it was cardiac. So we ended up doing an EKG in addition to everything. So is that still a good like thought process to go down then? I guess if the patient is having that trouble speaking during, and you've already given atropine, you're getting that irinotecan, and they have that almost change like with what they're able to like do and say.
I mean,
is that like a case by case?
I would say anytime it's like the first instance of something like that happening, it is completely appropriate to do any kind of full workup because, yeah, I mean, it looks like a stroke. I mean, it almost looks like stroke symptoms,
right.
And you know, after the fact, once you've seen it happen a couple times, like with this guy, I can say, okay, he's not having a stroke, it's an irinotecan. But the flip side is, you don't want to say, oh, this is probably irinotecan, and then 2 hours later be like, oh, it's not getting better. Oh crap, maybe you were having like a stroke.
The paroxysmal AFib that can happen
exactly.
with the atropine.
Oh yeah.
Because that cannot, like, if they throw into some sort of irregularity or something. I mean, I guess it's just kind of like, just want to make sure that we don't ignore something.
No, and so what I would say is definitely worth working up more fully, especially the first time, because you're right, it could be like a paroxysmal AFib, and I think if it was causing hemodynamic instability that would lead to like loss of ability to speak, there'd probably be other signs too, but you know, if they have AFib and they're getting things and they have that, they could also have like a thrombus and throw a clot, and that could be causing a stroke. And so like all these things are critical. And I mean, like anything, it's always helpful when there's a family member there, because usually they're appropriately or maybe inappropriately like concerned about things, but at least they're going to be like, no, this is not normal. This has never happened before. So just to go through, so in colorectal, the mutations matter. RAS and RAF status predicts response to anti-EGFR therapies or harm. And so one of the big findings when they initially did this study looking at adding cetuximab to FOLFIRI, they found that there was a survival benefit, but when they started to parse out looking at patients who had KRAS mutations versus not, what they found was that if you had a KRAS mutation, you actually had a worse outcome. And so that's the slide on the left. And you can see that it is no better than best supportive care to get cetuximab when you have a KRAS mutation. And if you actually look in the trials where they did cetuximab plus FOLFIRI versus FOLFIRI alone, if you have a KRAS mutation and you've got cetuximab added to FOLFIRI, your outcome was worse. So it's not just that it was not helpful, it was actually harmful. And so now you can't give somebody, you shouldn't give anybody EGFR inhibitors, and cetuximab and panitumumab are in the same family. We don't give a whole lot of cetux, but all the trials were done with cetux. You shouldn't give and you can't give unless you have done mutational testing. And then sort of newer data from the Beacon trial that was reported out more recently is that if you have a BRAF V600E mutation, you can target it with one of the BRAF inhibitors in combination with cetuximab, or probably with panitumumab, but the trial was done with cetuximab. So, and then I wanted to address the leucovorin, because We give glucagon for different reasons, for different patients. It's a folic acid derivative, so I tell people it's a vitamin. And so people will be like, oh, I'm getting 4 chemo drugs. I'm like, you're getting 3 chemo drugs and a vitamin. But for methotrexate treatments, it's a rescue. With 5-FU treatments, it's an enhancer, and so it makes the 5-FU work better. And without going into too much, and how much time do I have? When is this supposed to end?
8 o'clock.
8.
We're comfortable enough out.
Okay, good. So, so with 5-FU, it's an enhancer. And so what you can see here is, and I hate these diagrams because they're confusing, but 5-FU is converted by thymidylate synthetase into a defective DNA precursor. Glucagon works in this is the dihydrofolate, tetrahydrofolate, so these are basically the folate cycle for taking folate and incorporating it in. It's basically a catalyst for thymidylate synthetase. So when you put it on this side of the equation with 5-FU, it pushes everything to the right, and so it basically makes more of the 5-FU get integrated into this precursor, and it gums up this system. So it basically gums up the thymidylate synthetase system. Whereas with methotrexate, you're blocking the dihydrofolate receptor, so with methotrexate, you're blocking this cycle, and so what glucagon does is it basically dumps in on this end and rescues. And so it's a big difference because obviously with 5-FU therapy, we would want to give something at the same time that's going to prevent it from working. So it sensitizes, but with methotrexate, you're actually rescuing, so blah, blah, blah. Does that make sense? All right, and that's what I have for colon. Do you guys have any questions before I move on to?
How often are you checking CEAs on your colon?
That's a great question.
And how do you, like, isn't it environmental factors going to affect it too?
Yeah.
So I know some patients like cling on to those tumor markers.
Yeah.
So if they're on active treatment, or do you even?
So for adjuvant therapy patients, I try not to check it at all, because usually it just induces anxiety when it comes back at like 5.5 and you're 3 months into adjuvant treatment, and it's like, is this working? And I'm like, well, I don't want to get a scan for another 3 months. And so I try not to check it because I don't really want to know what it is. For metastatic patients, I try to check it about once a month, because every 2 weeks you can see variations that are not as helpful, but sometimes I just like sign the labs and it's in there, and it happens every 2 weeks. That's the honest truth. But I tell patients that essentially it can be helpful if it's elevated and the general trend is helpful, but the absolutes are not as helpful. Same thing with CA19. Pancreatic cancer, often undiagnosed at the later stages, as you see on the right. Patients usually present with symptoms related to either pancreas is failing, so like sort of acute onset worsening diabetes in the past year, pancreatic exocrine insufficiency, mechanical blockage of the ducts, so that's the jaundice patients coming in yellow, or pain due to a large tumor. So if you have a tumor in the tail, unfortunately, you usually don't get obstructive symptoms, and you tend not to have failure of the pancreas, and so it can get pretty big before people notice anything's happening. And so this is the anatomy, and really this picture just shows that the pancreas is sitting really deep. It's in the retroperitoneum, so it's behind a lot of other organs, and it's wrapped around the aorta, and just zooming in a little bit more, it's in a really anatomically difficult place, which is part of the reason why it's such a bad cancer. Showing, just to highlight some of these things, so this is where the gallbladder and bile ducts from the liver come down. You can see it kind of interfaces right between the duodenal papilla. So when you have a pancreatic head mass, that's why you get obstruction, because pancreas isn't producing the bile, but the mass here blocks that drainage. And similarly, we think about sort of the endocrine functions of the pancreas all the time, like the insulin production, glucagon production, but most of the pancreatic function is these acinar cells creating exocrine digestive enzymes, which is why a lot of these patients, I talk to pancreatic cancer patients about pancreatic insufficiency, need for creon replacement, support there. And you can see it's just tied in with a lot of, with the duodenum, with the major vessels, it's in a bad place. And so, for workup, you need to confirm the cancer with the biopsy, usually done with ERCP, which is, I actually had to look this up because I say ERCP, but what it stands for, endoscopic retrograde cholangiopancreatography. And then you need CT scans to look for local or metastatic involvement. And again, I never think about pancreatic cancer by stage so much as I think about it by, is it resectable? Is it localized but not immediately resectable, or is it metastatic? And so I'll take a second to go through what is borderline resectable. And so you can kind of think about it as you can remove it, cut it out immediately, versus locally advanced metastatic cannot be removed at diagnosis and probably will never be resectable, versus borderline where, like the name implies, it's borderline, but it's not ambiguous. So there's definitive criteria that define borderline disease. I like to think about it in this ABC, and I found this nice little schema that sort of breaks it down in a decision tree. And so the ABCs of borderline resectable pancreatic cancer are anatomy, biochemical staging, and then conditional staging, but it makes sense to think about it in reverse order. So the first is like, is somebody fit enough to go through a Whipple? A Whipple is a major surgery, often like a 8 to 10 hour surgery, lots of comorbidities, you're cutting out a ton of organs. So if you're not in great shape, you probably shouldn't start off with a Whipple, even if you could get it cut out. And I can think of one of my patients in particular that some of you guys have taken care of, who, I'll say he's a big fishing fan, but he is like, he's technically resectable, but his performance status is not outstanding, and he had like a stroke a couple of years ago, so he's like a hemi sort of paralysis, and he's just like not a great baseline. So we've started with chemo with him just to sort of see how things go. If you are otherwise resectable, but your CA19-9 is really elevated, greater than 500, then that's usually an indication that there's either high concern for micrometastatic disease or high chance that after resection you're going to recur with metastatic disease. So usually we do neoadjuvant therapy, and then the anatomical staging is based on imaging criteria. And essentially what it breaks down to is if there's greater than 90, if there's 0 to 90 degree involvement of any of the arteries and less than 180 degree involvement of any of the veins in that area, then you're borderline resectable. If there's more, then usually you're locally advanced and unresectable. Only in the settings where you're really not touching any of the arteries or veins are you considered just resectable. Any questions before I move on from that? And one of the concepts, and I'll talk a little bit about it too, is that for borderline resectable disease, I like this idea of prehab. So they say rehab in the decision tree, but like the idea of prehab is that like some patients you may be able to actually get them stronger by doing a little bit of chemo before doing a big surgery and get them better fit for surgery. And these slides are really just to highlight the fact that even in the resectable disease setting, we're moving more and more towards thinking about doing chemotherapy in all these patients because they're at such a high chance of recurrence. So if there's really any reason, and the surgeons here feel the same way, that if there's any reason to have even mild concern, we'd rather throw a little chemo at these patients before taking them to a big surgery. And so all decision trees essentially lead to giving chemo before surgery. And that's just what I'm highlighting in all these, that like, and what you can also see that basically the recommendation is always consider a clinical trial as a first thing before going to the standard of care therapies, which is why we try to have trials, first-line trials for pancreatic cancer patients. Guys are familiar with FOLFIRINOX, three drugs plus the vitamin. For 2 weeks via port with take-home pump. And so this is the initial survival benefit from the trial of FOLFIRINOX versus Gemzar. This is in a metastatic setting, and the takeaway is that it's better than gemcitabine alone. Clearly, it's more toxic, a lot more neutropenia, pretty significant neutropenia, and this is grade 3 or 4. So I mean, grade 3 neutropenia is basically when in the parameters it's like do not treat. So this is why it's sort of built into FOLFIRINOX, or it's not built in, but almost always I have a very low threshold for giving Neupogen or Neulasta because so many people get neutropenic with this regimen. Fortunately, not a ton of people get febrile neutropenia, but I think that's because they had it modified so that they started giving Neupogen sooner than later to prevent febrile neutropenia in admissions. This is the more recent trial. It's Protégé 24, and you'll see that the difference between the previous one was just FOLFIRINOX versus this is M FOLFIRINOX. And the M in front of FOLFIRINOX implies one that the irinotecan may be a little bit lower. So in this trial, they had irinotecan at 180 versus 150 as a starting dose, and in the second part of the trial, they basically mandated that 150 was the starting dose because 180 was too toxic. They also dropped the bolus. We talked about the sensitizing effect of leucovorin with 5-FU, and because 5-FU is cleared by DPD, which is in all the red blood cells in the body, it has a 8-minute half-life, and so the leucovorin works best as a sensitizer when you use bolus 5-FU. For whatever reason, they kept leucovorin in this trial, and so even though you don't have a bolus, they have leucovorin, so that's sometimes why we'll give the leucovorin even we're not doing bolus, and I think there's a rationale. Some people will drop it, some people won't, but that's the confusion. So it's not wrong to do it either way because it was in the trial, but sort of thinking it through, it makes sense that you wouldn't necessarily give it if you're not giving the bolus, blah, blah, blah. Anyhow, so the M implies that it's a little bit easier of a regimen to handle, and you can see that the overall survival, this is pretty darn good because overall survival for pancreatic cancer, even with Gemzar, you can see is at about the 20% range, and this doubles that to close to 40%. So, and again, it's more toxic, a lot more side effects, but you can imagine, especially for a young fit patient that had a resection, I almost always try to give them FOLFIRINOX because it's going to double their chance of long-term survival. Gemabraxine, 2 drugs, 3 weeks, 1 week off, and I was going to throw in some of the data, but then I figured I was going to start running out of time. So what I'll say is just comparing FOLFIRINOX to Gemabraxine, this is a debate that I have with a lot of patients, like, well, FOLFIRINOX is harder core and it might have better outcomes, but you can't really compare them because it's comparing apples to oranges. There's never been and there never will be a trial comparing FOLFIRINOX to gemcitabine. So even though the overall survival in the metastatic setting looks a little bit lower with Gemabraxine, it's because it's easier to tolerate, and so the people who get it tend to have a slightly worse performance status at baseline, and that probably is affecting why they don't do as well. This gets into the statistical planning of trials and thinking about things from a, you can't really make definitive decisions or definitive, you can't know for sure unless you do a RCT, a randomized controlled trial. And so what I wanted to sort of address too is that pancreatic cancer patients in particular, treatment is about more than chemo. And so I always talk about the chemo, but I always take a lot of time to talk about nutrition and pain control too, because what patients really struggle with is often a lot of pain, weight and appetite loss, often a rapid functional decline, even in the couple months leading up to diagnosis, and a lot of depression and psychological distress because pancreatic cancer is such a devastating disease that it's hard to wrap your head around that sometimes. And so NCCN has a nice summary of the things that you want to think about doing, but like, you know, if somebody presents with obstruction, it can be both biliary or even gastric outlet obstruction, duodenal obstruction, and so for patients that were going for aggressive therapy, we'll do aggressive things like putting stent in there, like even surgically bypassing them temporarily to make sure that they have gut continuity so they don't need to be on TPN or supplemental nutrition parenterally. If you're poor performance status, we will, and often inpatient, I have a lot of conversations with the palliative care team and patients when they're inpatient about doing like a venting peg, and so sometimes we'll put a venting peg in because if you're obstructed, it's not to give nutrition, but it's to give people the ability to take things in orally and then pop it and drain out so they don't get horrible refractory nausea vomiting from obstruction. And one of the worst case scenarios of pancreatic cancer is when you have peritoneal mets and it's locking down the gut and you get a frozen gut because there's just no fixing that. And so I remember one conversation particularly I had with a patient who was in his 70s and he had peritoneal mets and his disease wasn't so bad, he was feeling good. And he was like, well, I don't know, should I be thinking about doing more? And I was like, honestly, you probably don't want to live long enough to have the horrible side effects of your gut freezing from peritoneal metastases and being like in constant pain. So not that you couldn't handle more treatment, but your quality of life is probably going to be a lot worse if you survive a lot longer or even a little bit longer from treatment. So otherwise, these other things, so like pancreatic exocrine insufficiency, Creon, I ask people if they have loose floaty stools. So if you ever talk to somebody and they're not on Creon and they're like, yeah, I have like the worst bowel movements and their wife is complaining that they like stink all the time because they're passing a lot of like stinky gas. They might need Creon or replacement. Pancreatic cancer is also one of the most common cancers to give PEs and DVTs. So another reason if you have somebody who's got like loose swelling and like I missed it, you know, let me know. So just to run through some questions. You have a 47-year-old female, 3 months of abdominal discomfort, change in stool caliber. Otherwise, past medical history is negative. Rectal exam's normal. FOBT is positive. So, what do you want to do? Where do you want to send her?
Scans.
Yeah. So scans, colonoscopy. If it's colonoscopy, has a tumor. It's adenocarcinoma on biopsy. And so let's do some scans. No evidence of metastatic disease. Great. Who should she go to first?
The surgeon?
Yeah. Send her to the surgeons. Send her to Dr. Hedrick or Dr. Reilley. So tumor goes through the muscularis propria. It invades into, doesn't go through. But there's one positive regional lymph node. And so lymph node positivity makes you stage
3.
And so based on that, what do you do next for her? And you can deduce from the topic of this that maybe...
Yep. Chemotherapy.
Yeah, so stage 3 disease should get chemotherapy, and just to go back through this all again, you know, you can see on the left, stage 3 has those positive lymph nodes, and stage 3 should always at least have a discussion for chemotherapy. Because she's 47, she probably should get it for risk reduction purposes. And then, because she's 47, anything else you'd want to think about with her?
I'm not really sure what that IHC staining is, but do you need to do anything about, is the assumption at the time of biopsy that all of those fancy tests are done?
Yes, so you can assume that, and I mean, so let's say what if she came back with say mismatch repair deficient disease and like she was MSI high, what would that imply? And sorry, this is kind of I did not discuss this in this lecture, so but also just in young people in general, what's the kind of concern that you could have if you knew their family history? Yeah, so like the concern exactly is that they could have some kind of inherited syndrome. So At 47, that's young enough that I would at least consider sending him to genetics to have a discussion, certainly ask their family history, and if they had a compelling family history, and especially if they had mismatch repair deficiency in IHC, then there's a good chance they might have like a Lynch syndrome. So this next question, this is the last question, then I'll stop. 78-year-old metastatic colorectal cancer. She's had resection. She got chemo, but progressed on chemo, and now she can't care for herself and is mostly bedbound. So what's the next most appropriate step in her management? Not more treatment? So this is the ECOG scale, and you know, she's a 3, probably a 4. You know, only limited self-care, can't get out of bed more than 50% of the day, and this is, you know, I think we all see and give chemo to patients that are probably at least in the 3 category, and there's some evidence, especially with certain like lung cancers like small cell, that you can be 3 and actually bounce back. But for colorectal cancer, pancreatic cancer, if you're a solid 3 or 4, the chance that you're going to actually improve is poor. And so really somebody like this should be getting set up with palliative care and not be getting more treatment. I'll stop there. Questions?
Based on one of the trials that we're doing, I often get asked about, you know, talking about the oncos, route of administration, absorption. Can you discuss benefits of IP versus IV and absorption of?
Yeah. So for colorectal cancers, there's very little data supporting IP chemotherapy. The exception to that, and this sort of is due to similarities between peritoneal ovarian cancer and like low-grade mucinous appendiceal cancers, is that HIPEC makes sense for appendiceal cancers that are mucinous that you can debulk. We don't do HIPEC here yet, and I have mixed feelings about HIPEC because patients often like have a lot of complications after HIPEC. But there's not a strong role for IP chemotherapy in colon cancer right now. The oncos, which is actually an oncolytic virus, is the thought is that it's targeting macrophages, and there's some interesting data from a nephrologist here that suggests that looking at dialysis fluid from patients who get peritoneal dialysis, there's a ton of macrophages in the peritoneum, and so doing the IP oncos, which targets cancer cells, but also targets with a interleukin that stimulates macrophages, that you could potentially cause lysis of cancer cells, stimulate the macrophages to recognize those cells and generate an immune response. So that's the rationale for doing that, but I'd say unless you had a strong rationale and it was in a clinical trial setting, we typically shouldn't be doing intraperitoneal chemo for colorectal cancer patients. What else?
I think we're gonna have to go.
Sorry, I know you guys probably have to